One of the common treatment decisions, unfortunately, that we see in caring for people with advanced dementia is what to do when somebody stops eating or drinking. Or more typically, people don't actually just stop eating or drinking. They slow down, and they have difficulty eating and drinking. What may seem to be the correct solution is to surgically implant a tube into the stomach and provide artificial nutrition and hydration through a tube to prolong life. But as Mencken has said, for every problem there's a simple, straightforward solution that's wrong. So what's wrong with tube feeding? A number of things. First of all, we have a preponderance or a very large amount of evidence to suggest that tube feeding doesn't prolong survival in end-stage dementia. People don't live longer. Well, how can that be? We're providing them with nutrition. Well, there's a couple of reasons for that. The first is that, as I said, people really don't just stop eating and drinking, and that with very careful and meticulous spoon feeding, you can provide enough nutrition and fluids that somebody will continue to live for as long as the disease progresses. So that's a myth. The second is that tube feeding doesn't reduce the risk of aspiration. What causes a problem, or what causes aspiration pneumonia, is not food going into the lungs. It's all the bacteria in our mouth and in our upper airway that we swallow that goes down into the lungs, which is a sterile place. And so the worst pneumonias don't happen because somebody aspirates their food. It's because they aspirate their saliva and their secretions. Tube feeding doesn't change that. What are the harms of tube feeding? There's a number of harms of tube feeding. The first is that one of the great pleasures in life is eating and drinking. People like to eat. You put a tube in a person with dementia, that is gone forever. They don't eat or drink. And that simple pleasure is taken away from them. We have very good data that shows that tube feeding is associated with an increased use of restraints in people with dementia. That is, we tie people down so that they can't pull out the tube. We did that in the old days. Now what we do is we give them medicine so that they don't pull out their tubes. And I would argue that that's not good quality of life for people with dementia. And then finally, one of the questions that I always ask the relatives of people with dementia, I ask my patients with early stage dementia, and I ask my patients in an advanced care planning discussion, is tell me about what to you would be a fate worse than death. That you would rather die than be kept alive in that state. And for most, not all, but most, when they say, I can't recognize my family or friends, I can't take care of myself, that would be a state in which I would not consider life to be worth living. That would not be an acceptable quality of life. Tube feeding, overwhelmingly for somebody with dementia, happens after that point in time. So for most people, what I'm doing is providing a treatment that is maintaining a quality of life that they would find unacceptable. And I can, in good conscience as a physician, recommend that.
And the reality is that feeding with a tube, even directly into the tummy, doesn't stop aspiration. And now they have diarrhea, and they can't communicate and can't walk. So you add some very, very strong sense of loss of dignity. No person would want to be trapped in that situation.
The evidence that a feeding tube helps in that situation is exceedingly thin. If anything, the evidence is that it increases the likelihood of aspiration, increases the likelihood of shortness of breath. There's no particular advantage given. I've had patients like this on feeding tubes, and they don't metabolize what you put in. They don't make proteins. They don't heal wounds. The body has just really given out.
So We have evidence that if you have end-stage dementia, meaning that you're bedbound and requiring careful hand feeding to eat, that putting a feeding tube in is not going to prolong your life or give you quality of life. It's not going to prevent wounds. It's not going to prevent aspiration pneumonias. So I can talk to patients' families about that being more of a burden to put a feeding tube in somebody with end-stage dementia than a benefit.
And I think of a family that would be visiting their loved one in a nursing home with a feeding tube in. They would go in day after day to see someone possibly unconscious lying in a bed, curled up with a feeding tube, which is the only link to living. The patient may be living and suffering for many, many months, and the only thing keeping them alive is this external feeding tube. And then I would have to go back to the family and ask them to remove the feeding tube if the patient truly was suffering and not getting better. And that's an equally painful discussion to have with the family, because once a feeding tube is started, it's very difficult for them to have it removed. And I myself would never want to be in those circumstances, and I feel many people wouldn't either.
There is this belief that when you're ill and you don't feel well, you gotta have nourishment to get better. And when somebody is declining in their disease, they typically are not real hungry. Their bodies are trying to conserve energy, and they may not really feel much like eating. That's counter to what the family who's sitting there saying, "Dad, please, you gotta eat, you gotta get your strength back." Then the question comes up from the family, well, Dad's not listening to us. Is there a way that we can get around that by just putting a feeding tube in his stomach, and then we can give him a full course meal directly into his stomach? I think it's part of our responsibility as palliative and hospice physicians and providers to be honest with patients, to make sure that they understand that despite it appearing that it would make a difference, that they would gain weight, they would gain strength, they would be able to live longer. The reality for most patients is that it puts them at greater risk to developing an infection like aspiration pneumonia and is unlikely to really alter or prolong their life.